Commercialization is, to me, extremely important. I think the profit motive enhances clinical impact. It's not a dirty word to me. The FDA wasn't that bad back then. The first system for eye imaging went on sale in 1996, and that's only 5 years after our initial paper in the journal Science. I thought that was very fast. My career has mostly been in translational research, and there what's really important is making clinical impact in medicine. Rather than demonstrating the most impressive technology, I try to pick research areas where there's no technology that's being used clinically yet, but it's possible, it's plausible, and the technology is matured to a stage where that's possible.
In this episode of the 632 Nanometer podcast, Misha Xinghui and Mike meet David Huang, co-inventor of Optical Coherence Tomography, or OCT for short. David, a doctor and electrical engineer, noticed during his PhD work at MIT that he could image retinal tissue while working on measuring its thickness using laser interferometry. Today, David is a professor of ophthalmology and biomedical engineering at the Oregon Health and Science University and has continued to champion OCT over the decades as it gained clinical acceptance with 40 million procedures performed annually. OCT was enabled by advances in telecommunications systems such as diode lasers, fibers, and detectors, and has improved immensely in resolution and capabilities as the telecom industry made progress on the underlying photonics technology. The interview covers both the technical challenges and principles involved in the discovery, as well as the intricacies of bringing it to end users in the notoriously hard-to-innovate medical industry.
We have today a podcast with Professor David Huang, who is a professor of ophthalmology and biomedical engineering at the Oregon Health and Science University. And he is the co-inventor of Optical Coherence Tomography, a tool which most of us encounter when we visit eye doctors to check retina conditions. It has been about 40 million of these OCT procedures performed annually. I think this is really amazing about the tool which is widely used, and we're happy today to speak to the person who actually invented it. So you're widely known for, as I mentioned, for the OCT, which is optical coherence tomography. And could you explain to the listeners what is it and where they may have encountered more than, let's say, the visits of the ophthalmologist?
Well, I would define OCT as imaging with a interferometer using short coherence length light so that you can measure the round trip time of light scattered back from a sample or biological specimen with very high depth resolution, generally on a micrometer scale.
So where can it be seen? So I mentioned that it's usually used like for retina analysis. And how it was like, let's say before, how was the retina analyzed before OCT came into the game?
Well, before OCT, people are looking at the eye with something called a slit lamp microscope. And that projects a slit beam and with high magnification optics. The doctor then look at the eye directly. It could be looking at the front part of the eye, the cornea and anterior chamber, or in the back of the eye, the retina and optic nerve. And often there's additional aids like condensing lens or contact lens that they put on the eye to increase the magnification and aid in stereo perception. The slit lamp use stereo binocular optics, so there's a depth perception. But with OCT, you go from a stereo perception where you can see thickening of the retina on several hundred micrometer scale to being able to detect even small fluid pockets that's a few micrometers. So it's a 10 or 100-fold enhancement of the ability to see in depth. And of course, it's also a digital imaging modality, so you get a permanent record, and the images can be analyzed with computer image processing and artificial intelligence. It's also much gentler for the patient because typically we use infrared light that's not visible to the patient as compared to fundus photography or direct slit lamp examination that use very bright white light that's dazzling and uncomfortable. So it's used pretty much for all eye conditions. So if you go to an ophthalmologist for anything more serious than just needing eyeglasses, you probably will get an OCT scan, both for retinal diseases or glaucoma or disease of the front part of the eye.
So going back to the technical principle of OCT, is it correct then to say that because it's interferometry based, you have a reference arm, I assume, and then because it is incoherent light, you have a very short coherence length, so then you can pick the thickness from which you can obtain your signal. So is it the incoherence that determines the resolution part of this method?
That's right. There is low temporal coherence. But in order to get good signal, you want good transverse spatial coherence. So generally, we use a light source called the superluminescent diode, or for swept source implementation, a laser diode source. These light sources can be focused to a very small spot and can be detected with very high sensitivity. And it's really the development of these light sources plus fiber optics and advanced detectors in the 80s for optical communications that allowed OCT to be developed as a high-performance imaging.
That's very interesting because that's actually one of the questions that we typically ask. What would you say are the technologies that already had to be in place for you to be able to invent this? And so now it seems like that actually the boom of telecommunications based on fiber optic cable was important for your discovery. So you're not building something that's free space, but fiber is of substantial importance in your configuration?
That's right. So you don't necessarily need to use fiber optics, but it was really helpful to have simple, robust mode matching between the sample arm and the reference arm by using a fiber interferometer. And of course, fiber optic was developed mainly for optical communications that took off in the 1980s. So high quality fiber optics and fiber optic couplers were available around that time that enable us to build OCT systems. And the lasers, back then was pretty new too. And diode lasers and a variation called superluminescent diode, again, only become widely available in the 1980s.
This is actually something I was going to clarify because you do need coherent light for OCT, right? You need a laser source, not just a light source.
Generally, most OCT systems use a superluminescent diode. So it's actually technically not a laser because it's a more spontaneous emission rather than stimulated emission, but it's confined within a waveguide structure. So it has really good transverse spatial coherence while having a wide spectrum at the same time.
Okay, interesting.
So it's kind of, the light has properties like halfway between laser light and ordinary light. And that is ideal for OCT.
Was it also its coherence, optical coherence tomography, since it was like originally done with the laser, but then later you found out that actually you only need the spatial coherence and maybe not the temporal coherence, or maybe there's like a sweet spot in terms of what is the ideal light source?
Actually, we started out using a superluminescent diode. It's only recently that tunable lasers are being used in a swept source OCT. We started out using superluminescent diodes, which is technically not a laser. There were previous projects in Professor Fujimoto's lab that used femtosecond lasers to probe the time of flight of light reflected from biological specimens. And that did not use interferometric detection. The initial project used nonlinear cross-correlation or second harmonic generation, and that did require femtosecond laser pulses. But that was too difficult, I think, for a routine medical imaging application. And also, actually, the performance was not as good as OCT. So that was just a precursor in stimulating the thought process and project development. And that occurred, I think those projects were ongoing about 5 years before I joined Professor Fujimoto's group in the ultrafast optics group.
So it appears that when you joined, Professor Fujimoto already had the goal of creating instruments for biomedical imaging. What specifically was he interested in, or what did he task you to do when you first arrived as a graduate student?
I had several projects. One was building a picosecond laser system to cut tissue. So it's to amplify a picosecond laser with enough energy to cut tissue. We were thinking that it could be used to cut corneal tissue for refractive surgery, or cut the vitreous for vitreoretinal surgery. But I failed in that. I never could get high enough energy to do cutting. So my fallback was to do the second project, where my goal was to measure the thickness of tissue layers. Initially, we were thinking of measuring corneal incisions in radiokeratotomy or excimer laser corneal surgery. So it's simply measuring thickness was my initial goal. And we extended that to measuring the retina, measuring retinal thickness. And when we look at the retina, what I realized from the data was that I wasn't only just seeing from the front and back surfaces of the retina, but the instrument has such high sensitivity, 100 dB or 1 in 10 billion sensitivity, that we could actually see internal structures inside the retina. And that's what gave me the idea that this could be turned into an imaging modality, because we were seeing internal structures. So we changed the goal of the project from simply measuring thickness to developing the imaging technology.
How would you see it? Was it an interferogram, which was later like Fourier transformed, or was there any temporal analysis involved? So depending on the length of the tissue, there would be like different time stamps for those signals, or if you could explain that part.
So the initial setup was a time domain OCT, or at that time, since we were not scanning, it wasn't even OCT. You could call it optical coherence domain reflectometry. So we have a Michelson interferometer, and with a superluminescent diode light source that provide enough spectral bandwidth to have 10 micrometer depth resolution. And initially, we did not use fiber optics. So it's a free-based system. You have a beam splitter, and we match the length of the reference arm and the sample arm so that they were approximately equal. And then the reference arm length was modulated rapidly with the motor that changed the position of the mirror. And as it scanned back and forth, it generated an interferogram. You would get a signal peak when the distance to a tissue layer is matched by the distance to the reference mirror. When we scan the retina, we'll see signals from the various layers inside the retina.
So you measured the reflectance of different intensities on which layer it happened in the tissue.
Right. Since the reference mirror is scanning back and forth, as you were saying, the depth in the sample will be time-coded. So you plot the signal amplitude versus time, and that provides the axial scan.
Mm-hmm. And you did it with continuous wave laser. It was not pulsed one.
It was not pulse.
Okay.
It was a superluminescent diode.
Okay, yeah, as you mentioned, you started from superluminescent in the ultra-fast optics group, and you stick with it.
We actually have to modify a laser diode to produce superluminescence. So basically, you take a laser diode and you coat the facets to reduce the reflectivity, so it doesn't have sufficient gain to laze, but produces wide bandwidth light on a continuous basis.
Why is it better to use wide bandwidth light? What's the benefit of having multiple wavelengths?
That reduces the coherence length and your spatial resolution in depth. Your axial resolution is inversely proportional to the spectral width. That's how OCT works.
What happened after that? You were measuring the depth of those tissues in the eye. How did you end up with the OCT, what is known, let's say, these days, or what is described in 1991 paper?
Well, for the first demonstration, we simply put a retinal sample on a motorized stage and scan the sample under the beam to get a transverse dimension to build a cross-sectional image.
When you say retinal sample, is that from an animal or another grad student?
Oh, it's definitely not a student. We started with calf eyes, and we cut off the front of the eye and just directly scanned the back of the eye, which is the retina and optic nerve head. And once we know that it works, we got a cadaveric human eye and did the same thing. And after we demonstrated that the imaging worked, then we worked to improve the sensitivity and speed of the instrument so we could do clinical imaging through the pupil in a human subject. And that didn't take long either. It took about a year to go from lab benchtop imaging to clinical imaging of human subjects.
I read somewhere that animals, they have like a reflective coating behind the retina. So that's why you can see the eyes glaring at night. Is there a difference when you do OCT on human retina or the animal one in terms of does it perform like the resolution or the quality of the OCT scan?
Well, it doesn't really make OCT any easier or harder. You would just have a very bright layer behind the retina that you can see as a bright layer or signal peak on OCT. Yeah, animal eyes are interesting. You know, some animals have that additional reflective layer. Some animals have no foveas. Actually, most animals have no foveas. And some have two, like birds. So that's interesting. But we started with calf eyes, cadaveric eyes. Then we imaged rabbits, and then we imaged human subjects. Since it's non-invasive, the light level is comfortable and very safe. It was not a problem to do human imaging at all from the start. And Professor Fujimoto was the first volunteer. You know,
Wow.
I went around the lab and asked people if they would volunteer, and my fellow students were not all that willing to help. They're like, "You're gonna shine a laser beam in my eye?" Yeah, right.
Professor Fujimoto really trusted in your setup. At that time, did you realize the importance of what you observed that you can do like the imaging of the retina tissue non-invasively? Was it like obvious from the very beginning that this is like, wow, this is a big thing which could change how the retina imaging is done and could be implemented in the hospitals or in ophthalmology? Yes.
Well, in a vague way, you know, I'm an ophthalmologist now, so I know the eye very well. But back then, I was just a MD PhD student, and I didn't know all the eye diseases there are that could be diagnosed with this. But I have some idea because with this technology, you can see different layers in the retina that there's no way by direct microscopic examination that you could see. It looked very grainy, and there's a lot of motion artifacts. So it didn't look very impressive, but you know that it's doing something that was not possible before. And of course, these days, the OCT systems we use in clinic are many thousands of times faster than the initial machines, that prototypes that we use. So the image quality is much, much higher now. And there's definitely no doubt that the kind of details you can see would not be possible with direct microscopy.
Actually, that's a very interesting fact from your biography. I find really like unique and fascinating that you got a double degree in MD degree as well as the PhD degree. So could you maybe share what happened? How did you end up getting these two degrees, and how did it also help you, let's say, with building the OCT and then like later in your career?
I think I got so many degrees because I wasn't sure which way I wanted to go. I was a little bit lost. I was in course 6 as an
Electrical
undergrad.
engineering. Is that
Yeah,
electrical engineering
e-
and computer science?
electrical engineering and computer science. I don't know if that's all reorganized. I think everybody's in computer science now, right?
Yeah, it has just been reorganized, but yeah, course
Yeah.
6 at MIT at that point was computer science and electrical engineering.
I was actually pretty good programmer, and as an undergrad, I had summer jobs doing programming, actually programming the basic mathematical functions in some statistical package, which I found very boring. And so that set me up to go to medical school because I thought that working with actual human beings would be more interesting. That,
Have you considered law school?
have I considered? No, I never considered law school. I never thought of myself as a very good speaker or writer, but I thought curing diseases, treating patients would be stimulating, interesting, and worthwhile. So I got into medical school. I was in the HST program, the Harvard MIT Health Science and Technology program. And initially, I thought I would just get the MD degree with a technology bent. But midway through the year, I talked to Professor Raphael Lee, who I knew from a quantitative physiology class that I took. And he was both a plastic surgeon and a professor in the continuum biomechanics groups at MIT doing connective tissue research. And he convinced me to join him as a research assistant building an artificial ligament from collagen matrix and fibroblasts. So that's because, one, I actually miss engineering. Once I got into medical school, I missed the analytic quantitative aspect of using my brain that way. And also, he promised that it would pay for my medical school, which was also attractive. So I did that for my master's degree, but I found that tissue culture, cell culture was too slow and tedious for my taste. And I read about all these laser applications in medicine. Around that time, excimer laser refractive surgery was in the news. So you can use lasers to treat the eye. Of course, it was being used in dermatology
Was it that
and
the LASIK surgery?
LASIK surgery. Yeah. So I looked around for laser related projects. I look at Massachusetts Eye and Ear Infirmary where they had a laser lab. I visited spectroscopy lab, Professor Michael Feld's lab. Then I think it was in mechanical engineering. And I visited Professor Fujimoto's lab. He had a collaboration with medical people, ophthalmology people, and he was right next door. My master's thesis project was done in building 38 on the third floor, and I walked across a land bridge to building 36 and visited Professor Fujimoto's lab and looked at all the femtosecond laser systems that they had, and it just seemed very interesting. But the physics, it's interesting that many different things you can do in medicine, at least conceptually, was very appealing, and that's why I switched over for my PhD topic, looking into lasers and optics.
Nowadays, AI is really very popular like among the students. I'm sure most of the MIT students would like to join like CSAL and go into coding, develop a next generation of large language models. What was at that time, like in 90s? Was the ultra fast lasers also among those really like attractive technologies, or how was maybe like the atmosphere of that time?
I think genetics was the biggest thing in biomedical research. So working on lasers and optics is a minority area. And I always have been in a little bit off the mainstream, I want to say. Most people were doing genetics or immunology research for their PhD, even in HST.
Was that a conscious decision or you were just drawn to other topics?
Well, I wanted to stay in engineering and physics because I thought I was just better at it. It would just seem more natural to me and more interesting. I could never really remember all those different cells and receptors and molecules. It just seems very confusing to me.
So with OCT, we've touched upon this a bit before. Would you say that it was a solution that was provided for a problem? So did Professor Fujimoto going in already feel like, okay, there's probably a bunch of retina diseases that we could better diagnose if we had a method such as OCT, or was it a solution to then the problem you found afterwards? Like
Well,
what came first is a chicken and an egg question.
our initial target actually was the cornea because of laser refractive surgery, either radiokeratotomy or excimer laser PRK, which were available at that time.
So the eye was always the target. Like you didn't think through like, okay, which organ should it be or whatever. Is it because the eye is clear, or what's the reason that the eye was the target for this kind of?
Well, it's on the surface. It's easily accessible. So that was the initial target and the initial demonstration. And then we were thinking about other small critical structures, and we looked at a few things. Retina was a top suspect or target, and coronary artery plaque was the other. I also look at other things like potential endoscopic applications. So we look at things like gastric mucosa. I basically went around the medical school and got samples from people. And amazingly, people were willing to give me samples, human tissue to image, even though I was just a medical student. I don't remember how I managed to do that. I don't generally think that I'm all that persuasive, but two things really worked out by 2016 when we were asked to write a retrospective review. Imaging in the eye, predominantly retinal imaging was the number one application, and intravascular imaging of coronary arteries was number two, and that has grown a lot since then. Our simple guesses back then, based on looking for small critical structures, worked out really well.
Why didn't this get adopted for example, colonoscopies? Like, why do people not perform tomography in the colon?
People do that.
Oh, they do that. Okay.
Yeah, there are endoscopies. I think that number one target is actually esophagus, looking for dysplasia in Barrett's esophagus, which is a precancerous condition. You can also use it to look at gastric mucosa. And from the other end, you can look at the colon. And you can also image genital urinary tracts. You can image the bronchi and the lung. But these are not mainstream clinical applications because to detect cancer, it's the OCT resolution, although high, generally you don't see individual cells. That is one limitation. And another is that these other organs are very large. The retina imaging areas usually several millimeters, whereas when you're talking about the inside of a colon or the skin surface, it's 2 or 3 order of magnitude larger. Mm-hmm. But I think they are becoming more possible now because the speed of OCT is much higher now. Since the beginning of OCT till now, the speed has doubled about every 2.5 years. So initially, we were able to just get cross-sectional images of a few millimeter. And even then, it was kind of wavy because of all the motion artifact. And as the speed gets higher, you get pretty much motion artifact-free cross-sections. Then it went on to 3D volumetric imaging, and then wider field 3D volumetric imaging, imaging larger wide field, imaging repeatedly so you can detect motion signal, and that's the basis of angiography, which is what I've been mainly working on for the past 10 years or so, extending OCT to looking at perfusion down to the capillary level. And there are other contrasts. For example, we are now looking at optoretinography, or looking at the lengthening of the rods and cones as they are visually stimulated. And that requires very high speed and very high precision, being able to detect changes of a few nanometers. And that's become possible. And I think imaging larger organs is going to also become possible now with a higher speed.
Yeah, I'm really curious. So the paper came out in 1991, and then how long did it take for the ophthalmologist to start using it? What was the time frame between it was like conceived, the OCT, and then it became like the standard of the retina scans?
And FDA approved.
That's right. Yeah, FDA was definitely, I guess, part of that.
The FDA wasn't that bad back then. The first system for eye imaging went on sale in 1996, and that's only 5 years after our initial paper in the journal Science. I thought that was very fast.
That's extremely fast.
Yeah.
Yes.
Going from initial laboratory demonstration to an FDA approved instrument. And then in the year 2000, it received a CPT code. That means there's a special code that's recommended by the American Medical Association, and that would get reimbursement from Medicare and other insurance. That's also very fast. These days, you would expect double the delay, but those were not the main impediments. I think initially, clinical acceptance took some time. The first two models, OCT1 and OCT2, marketed by Zeiss, were sold only to major academic centers. And some retina specialists especially really saw the potential and were big fans because they recognized you could see new things, details that they could not see directly on OCT. Whereas I think most ophthalmologists actually thought it's like a toy that produced grainy images that looked very strange. But there were a lot of clinical publications on applications in various eye diseases, and that started to catch on in early 2000. The main application that became really popular was just simply measuring retinal thickness and edema in age-related macular degeneration that was starting to be treated with injections in the eye, with antivascular endothelial growth factor treatment that were effective in taking away that edema and loss of vision. So now you can measure something, prescribe a treatment, and then see actual clinical benefit. And this was a disease that was the number one cause of blindness. So it was a major breakthrough. So around early 2000s, OCT really, found a killer app.
Is that the antibody drug?
Antibody drug, yeah.
How does it work
Anti-VEGF
exactly?
antibody.
What's the mechanism?
VEGF is the molecule that was critical in the growth of abnormal blood vessels, and also it increased the leakage, fluid exudation from those vessels that cause swelling of the retina and loss of vision. So when you block the VEGF molecules with antibody fragments, so that they don't reach the receptors. You actually cause involution of the neovascular membrane and also reduce exudation from those membranes. And then you restore a normal retinal anatomy and restore better vision.
Why was OCT needed there in order to diagnose it or to find the place in the eye that it was happening, or?
OCT allow you to see the change in retinal thickness, and you can see fluid pockets. So you can measure the edema, and you can also see the abnormal blood vessels, the neovascular membranes under the retina on OCT. So using OCT, you can identify patients who would benefit from these injections, and then you can assess whether the treatment is effective or not by measuring the thickness of the retina, most importantly in the central retina. And that became a treatment endpoint that's very accurate, because some people would have improvement in vision, some people would not. Just measuring vision is not a very reliable way of really validating the activity of the drug. But measuring retinal thickness is a more reliable way to monitor the treatment.
So that AMD, before it was under the radar completely, people would just get blind and no one would knew what to do with it and how to treat it. And then with the OCT, that was the possibility to diagnose people with AMD.
With OCT, you can see these lesions at an earlier stage, and you can also see edema more reliably. Before, often you can see these lesions at a more advanced stage. For example, when they bleed and you have a big red spot on the retina, it's not hard to see it directly on slit lamp microscopy, but then it would be too late to intervene, because often the vision loss would be irreversible. You can also see leakage on fluorescein angiography, and that's injecting a fluorescein dye intravenously and looking at the fluorescence, which was also a significant imaging innovation. But that's more invasive, and you don't see the neovascular membrane as reliably as OCT can.
Maybe going back to one more technical point, you were mentioning the Moore's law of OCT, where the speed doubles is every 2.5 years. What is the main limitation to speed, and what can be done or is done to increase the speed?
I think initially the limitation to speed was the need to scan the reference beam length mechanically by moving a mirror back and forth. So that's a mechanical limitation. Later on, with Fourier domain OCT, where you use either a spectrometer or a tunable laser and a fixed mirror in the reference arm, there's no longer a mechanical limit. I think the limit then becomes the speed of either tuning the laser or the speed of the line camera used in spectral domain OCT. So the limit becomes the speed of laser tuning in swept source OCT and the speed of the line camera, how many frames per second it can capture. And those have been increasing steadily. I think at the current stage, what's the limit is that you can only use a certain amount of optical power safely in the eye without risk of damaging the retina. And that means the amount of light you collect is limited. And we actually reach quantum noise limit in that even if you increase the frame rate of the camera, you can acquire an image faster, but then the signal to noise ratio would be unacceptably low. So that limits the acquisition rate to several 100,000 axial scans per second currently. I think the way around it are either going to be a parallel acquisition or shining multiple beams into the eye at the same time, each one of which have safe enough low power.
Or if you want to be extra fancy, you can use squeezed light to go sub-short noise.
No, that's typical and limited yield. Or you would need to increase the optical power, but guarantee that the laser beam never stops moving. It never dwells on a single point to heat up the retina excessively. So the amount of optical power you can shine into the eye is the limitation right now.
What is that power typically? Microwatts or what is it? And I guess it's over area, but in what range is considered safe at the wavelengths you use?
At 800 nanometer, it's about 0.7 milliwatt. And
That's, yeah.
at 1050 nanometer, which is another water transparency window, you can go up to, I think, something like 5 milliwatts. It's probably feasible.
Regarding the cameras side, so you said it's like 1050. Are you still using the silicon CMOS ones? And my other question is on the sensitivity side. Can you improve it by using like more sensitive cameras, something like EMCCDs? I know it may require, like, they're more expensive and require like special cooling, but would it push further the frontiers of the OCT in terms of the speed of the scan?
More sensitive detectors certainly helps, but I think the detectors are already quite sensitive in terms of the quantum efficiency. And so there's not a lot of headroom for gain by improving that.
And you still use, is this just the traditional silicon? Because you feel like it's at the boundary of the band gap of the silicon, the wavelength you're using, or you have to use those like indium gallium arsenide, or like 3.5 type of detectors, which I guess also may increase the price.
Yeah, at the longer wavelength, generally the 3.5 types of detectors. And that's what tunable laser or swept source OCT is generally used in that implementation. Whereas at 800 nanometer, generally one would use a spectrometer, spectral domain OCT, and CMOS cameras, line cameras are generally used.
Are there any water transparent windows at even lower wavelengths? Because I suppose you could get better resolution if you could work at a lower wavelength. Or are those
shorter
more
wavelength?
damaging?
Sure. In our laboratory, we're using visible wavelength. I think for retinal imaging, it's really more experimental because it's too bright to easily use in the clinic.
Yeah, because of the reflex of wanting to blink your eyes. Yeah.
Constrict the pupil, and even if you pharmacologically dilate the pupil, the patient will find it difficult to tolerate. And
right.
The benefit there is that at the in the yellow-green region, you can use differential absorption of oxy and deoxyhemoglobin to measure oximetry in the retina, which is very interesting for research. But I doubt that that would be used widely. We also have visible wavelength OCT to capture finer details. And we also have a project for corneal OCT. I think it might be easier to tolerate if you image the cornea. So by the time it gets into the eye, it would be extremely wide field illumination, and it would be easier to tolerate.
I just went to an ophthalmologist recently, and then when they do the cornea scan, is it also done by the OCT scan, or?
Yes. Yeah, you can have corneal OCT.
Interesting. Yeah, that was really cool to see the topology, and they would explain what like the abnormal.
Yeah, so the standard OCT system can be used to scan both a retina and a cornea, sometime by internal adjustment, sometime by adding a lens to change the focal plane. But those generally use infrared light, and the transverse resolution is generally in the order of 15 to 20 micrometers. You can have stronger focusing to look at cell resolution that's called OCT microscopy. And with visible wavelength, you can see smaller features, even bacteria, which is one frontier that we like to work on. But generally, infrared is more clinically useful.
Do you always have to sweep the laser or tune the laser, or are there certain things that can be diagnosed even at a single wavelength?
Well, OCT by definition almost it requires a wide
Okay, to create that.
to
Okay.
create the actual resolution. Otherwise, you would just have it would
Right.
be a
It would just be
scanning
regular
laser ophthalmoscope,
interferometry. Yes.
which doesn't have the depth resolution that you want.
I see. Shifting a little bit the gears, I'm curious, back in 1990s, you were like the inventor of the OCT. And then let's say like nowadays it's like really popular if, let's say, when at MIT and you found something useful, you would like to start a startup. So now it's like very kind of big trend of students or like grad students would transfer their inventions into the startup, creating the company. How was it for you? Did you have this kind of consideration? Did you think of starting your own company based on this technology?
I have done startups now. I have a couple of startups, companies. But back then, when I was an MD, PhD student, I was not savvy that way. So I didn't participate in the startup activity for OCT. But fortunately, Eric Swanson and Jim Fujimoto, co-inventors for this technology, they started a company, Advanced Ophthalmic Devices, to develop the clinical instrumentation and to find a strategic partner to take over this product, to license the technology from MIT, which they did in just a couple of years to Humphrey Zeiss. And I think that startup drive was the reason that OCT had a big clinical impact so quickly. If they hasn't done that, it might have taken much longer. So definitely commercialization is, to me, extremely important. I think the profit motive enhances clinical impact. It's not a dirty word to me. And I certainly applaud that MIT students are becoming more aware and more knowledgeable on how to do that. Sadly, I was not precocious that way.
Having gone through this process multiple times now, at which point do you think does it make sense for a new invention in specifically the medical device field to leave the lab and be pursued commercially? Like, do you think it's at the point of having an idea, a full prototype? What is a good time to move this into a more focused commercial endeavor?
I think commercialization is appropriate when you know that the technology works and that you have an idea on how to build a product and how to market it. You have to identify a market or need for it. And you want to know how to build a product. If you're still exploring various technological options, it may be better to keep it in the laboratory and depend on grant funding. Because once you raise venture capital, you are on a really more of a strict timeline to make milestones, and there will be very little time for exploration. And if you do your exploration, then your options would be limited to what is time expedient, which may not be ideal to what you want to do.
That's an excellent point.
You mentioned you're now involved into several startups. Could you talk about them?
Yeah, my first startup where I was the principal was a company now called Go Check Kids. And the idea was to use smartphone flash photograph at a certain prescribed distance and ambient light level to detect amblyopia risk factors or lazy eye risk factors, which include strabismus or misaligned eye and refractive errors. And it's now being implemented on iPhones. And we've screened more than 5 million kids already. The advantage over the previous technologies is that it improves rapidly with the new versions of iPhone or smartphone in general. And it's integrated to electronic health records easily and securely. And the hardware is relatively cheap, so you can have many copies. And the company is ongoing. We launch into a second area of hearing screening. So generally, these are for well-child checks by a pediatrician. So our customers are pediatricians. So that's one startup. I was the CEO for a few years and then handed that off. So now I'm a board member and the chief innovation officer.
Were you working full time during that time as a
Yes.
CEO?
It was very difficult in the first few years because doing raising money and developing a product took a lot of time, which is difficult when I also see patients and have a lab to run. So it's definitely not for the faint of heart.
That's pretty impressive. That's very, very impressive.
Yeah, I really find it like fascinating. I think it's definitely a way to go for early diagnostics. So telemedicine, when you can use those built-in cameras in smartphones and maybe scan like some other parts of the body just to understand how serious is like fell or something happened before you go to ER or some other places. So if it's like an emergency, let's say.
In terms of like the general landscape for imaging, I'm just curious if you think about this. What's the future of imaging, or what are the missing imaging technologies, or the ones that are possible but haven't been commercialized or anything like that? What's the OCT of 2020s? Like something that is now becoming possible but isn't commercial, or where there's a need to image something but it's impossible today, something like that.
I think oculomics is one area that I am really interested in, and that's imaging the eye to diagnose systemic diseases, primarily cardiovascular diseases and neurological diseases. So, for example, we can image the central retinal artery and measure its flow and the pulsatile waveform, and could infer from that carotid artery disease and aortic valve diseases. It's easier to do a simple eye scan compared to going to a cardiologist for a cardiac ultrasound. And you can see changes in the retina and optic nerve in neurological diseases. For multiple sclerosis, that in most cases have changes in the retina and optic nerve, and in dementia as well, both vascular dementia and Alzheimer's disease. So those are projects that I'm really interested in, so that OCT can be used not just in the ophthalmologist's office, but also in family practice, I hope, which is would make a larger impact.
Can you breed OCT maybe with VR headsets, so that I know they like integrate now a lot of optical sensors like iris scanners? Can you put a retina scanner?
Eventually, I think that's going to happen. If it is possible to put OCT on a chip with integrated optics, and that would make it much more compact, potentially even higher speed and more economical, and being able to integrate into portable devices and virtual reality and headsets, and maybe that could bring it into the home, which is even a wider market than your family practice or internal medicine doctors. But I think that's a little bit further out, that I don't think that would be in the next 10 years.
Is anyone working on that right now, on putting OCTs on chip, or is there not enough of a business case or the application for that to happen yet?
There are definitely people working on that. I'm very much interested in that as well.
Right.
And I think that would be a very active area in the next 10 years. And so I think in 20 years' time, perhaps, that would probably be a reality.
Is like the light source the main problem? Because I know for optics and photonics, like we know that we can make like the chip which would do like guiding, but then usually the source is the kind of the main bottleneck. Or even for I've seen an OCT device from, let's say, Thor Labs. So they have a small OCT, relatively small OCT module, but then they have like a huge box with the rest of the, I don't know, like power supply or the lasers, the light sources and detectors. So I'm curious about that infrastructure which supports OCT.
Well, you have to build, if you want to build a whole OCT system on a chip, you have to have the light source, the interferometer, and then the detector, and probably A to D, analog to digital conversion. So it's a fairly large integration, and I'm sure if you have a few $1 billion, it's quite doable. But I don't know if the market will support it, because you have to sell many copies to recoup that cost. So that's probably the main limitation. So we probably need to piggyback on other applications. In the beginning of this interview, we talked about OCT piggybacking on optical communications, which invested many billions of dollars in this industry to develop things like detectors and fiber optics and diode light sources. If we were just having OCT as an application, the cost would not be justified. But because optical communication is such a large industry, it was able to support all those investments to develop all these high-tech components. So I imagine integrated optics will become easier and easier to do, and the cost will come down eventually.
That's a very good point. For example, right now I have one project where I'm building on-chip squeezed light sources with all of the same problems that you have outlined. But the quantum computing industry is very interested in this, so they are bankrolling these type of things. And then it's good to see that some of that will then downstream also benefit medical applications.
Right. Yeah. Squeezing light is probably even more esoteric application, or
It's very
less
esoteric.
frequently used.
Yes. Interestingly, there is quite a bit of interest from the quantum computing community in particular.
That's great.
I have a question in general about the OCT since it was conceived and then it propagates, like develops till these days. What are like the other rivaling technologies which was like at 1990s and maybe appearing through these days? If you could tell us what was the competitive landscape?
There are many optical imaging technologies for the eye, for example. Polarimetry was a competitive technology for measuring the retinal nerve fiber layer by measuring the birefringence instead of measuring the thickness with OCT. It worked, but it's no longer competitive because OCT can be used for so many different applications, and that was more of a single-use application. Adaptive optics was originally developed for astronomy and was borrowed to increase the resolution of retinal imaging, and that can increase the resolution both in terms of transverse and axial dimensions, and can detect single photoreceptors. And that is still used in research quite a bit. There's a lot of adaptive optics imaging to look at diseases and physiology. But it hasn't taken off in clinical imaging because it tend to be limited to very small area of view. Field of view is typically less than a millimeter, whereas OCT generally images several millimeters area, which is what you need for most disease detection. It may be possible that the cost and field of view for adaptive optics will be improved in the future to make it more practical. But that's a technology that developed about the same time as OCT. That's still being developed. Photoacoustic imaging can get you molecular contrast because OCT primarily detect just reflectance of a structure and doesn't have molecular specificity as you can do with fluorescence or spectroscopy. So photoacoustics is based on absorption, so that can have spectroscopic contrast more easily. But that also has its limitations and is still more in a research stage. It hasn't really taken off. Fluorescence light time imaging is another technology, and that can have molecular specificity. It's tend to be noisy in terms of being able to resolve different types of molecules, and it's also haven't found widespread clinical use. As you can see, there are many imaging modalities that have been explored in research, but it's actually a very high bar to reach to be used widely for disease detection and management. I feel very fortunate that OCT turned out to be so easy to use and so useful.
As a patient of OCT, are there any like side effects or any like influence on the health? Because I know, for example, other tomographies like CAT scans, there is like a lot of exposure to X-rays which can cause like cancer. Are there any issues related with OCT? I don't know, the light sources which expose the backside of the retina or something else?
Not that I know of. The energy level, the power level is so low that the rise in the retina is low enough not to have any adverse or therapeutic uses. There are people who use laser to stimulate the retina or retinal pigment epithelium for therapeutic uses, but OCT power is not quite that high. And infrared light, as you know, is non-ionizing, so it doesn't have the risk that X-ray would pose. Generally, it's very safe.
Very patient-friendly.
Very patient-friendly, yeah.
One question that we like to ask all our guests is, if you had infinite resources, be it financial or grad students, human resources, what is a project you would really like to do?
If I have a lot of resources, I would put OCT on a chip so it can be used for all those different applications that I talked about. Once you develop the base technology, making more copies would be economical, and then you could broaden the variations and applications dramatically.
What's the performance that it would have to achieve on a chip to be useful? Let's assume like you can't get immediately the same performance as like the best system. What's the minimum performance that the chip has to reach? Like in terms, I don't know what the right figure of merit is, like how broadband is the source, or I don't know.
Yeah, how broadband the source is a major limitation. And currently, commercial OCT has about 5 micrometer axial resolution, and ultra high resolution system can go down to 2 micrometer without a lot of difficulty. So I think for most applications, if you can have 5 to 10 micron resolution, it would be quite useful. You would not sacrifice a lot of applications. The speed I expect will be much higher with integrated optics, in that you could easily have multiple beams that would overcome the speed limitation.
But what it would translate, let's say what you mentioned, like the resolution into the required bandwidth of the lasers.
Mm-hmm.
Like how good they need to be, or like the sources.
What's the tuning range of the laser that's needed?
Oh, yeah. Generally, it's about 50 nanometers in the 800 nanometer range wavelength, and about 100 nanometers in the 1050 nanometer wavelength. There's also 1310 nanometer wavelength, where generally you also have 100 or 150 nanometer bandwidth. And those are the ideals. I think you can be slightly short of that and still be very useful. Sensitivity, quantum yield of the detector and the whole interferometer lost inside the light path could be a concern in integrated optics. And that's probably one area where the work needs to be done, because you want to be highly efficient to maintain the high detection and high speed at the same time. High detection, sensitivity, and high speed.
And what is now the most expensive part of the OCT setup?
It's either the tunable laser or the very high speed A to D, or the very broadband light source in terms of spectrometer-based OCT.
That's interesting. I have heard this bottleneck from other areas as well. It seems like a very kind of universal problem, which I think definitely if we can.
And high-speed cameras
somehow-
are expensive too. High-speed cameras.
High-speed cameras, okay. That's very interesting. What would you say to current generation of young researchers? What kind of advice would you give it to them by looking at your research career and what happened to you? And is there anything you would tell them?
Well, I wish I learned more about commercialization and forming startup companies when I was younger. But I don't think they need my advice on that. I think people going to MIT these days are much more knowledgeable than I was.
Surprisingly, no. This is still a big issue. In the physics department, most people do not know that they can file for patents. And so this is still very relevant point. It is more known in the electrical in course 6 land, but not so much in course 8.
I see. So it depends on the department. And my career has mostly been in translational research. And there, what's really important is making an impact, for me, clinical impact in medicine. Rather than demonstrating the most impressive technology, I've mentioned many imaging technologies that have been investigated at about the same time as OCT development. I pretty much stuck with OCT rather than going off on other tracks, because I wanted to stay focused on making clinical impact. I want to do something that's practical enough that we can use in clinic, and that kind of limit the choices a lot. And a lot of people like to play around with more things that seems more novel or have just its own technological appeal because something of a new type. But I try to stay clinically relevant.
So I think that's because you also went to medical school. I think for you it's probably a little bit easier than for a lot of engineers. If you were an engineer, how would you increase your surface area of contact with reality in terms of, like, let's say you want to make an impact on like the medical field or whatever? How do you even find, I mean, it's an extremely opaque field, right? So how would you like increase your surface area and your understanding, like your contact surface area, with the reality of what's needed? Because the information is not equally distributed, I would say, for sure.
Well, I've been impressed with a lot of engineers, PhDs, who don't have MDs, but know the disease applications really well, whether it's in ophthalmology, cardiology, or neurology. And I think they do that by talking to clinicians, by going to clinical conferences, and by being very widely read in the clinical literature. So it's not impossible for a PhD, or you don't even need a PhD, for an engineer to have an appreciation of the clinical applications.
What's the best conference to meet like the innovative or big picture thinking doctors that have thought through the needs and see where the opportunities are?
For ophthalmology is ARVO, Association for Research in Vision and Ophthalmology. And I'm sure in other research fields there are conferences like that that gather together clinicians and researchers.
I mean, the big vision is probably, if you're an engineer, is like, how can you build an eye? Like a replacement eye is probably the holy grail, right? Mm-hmm. Is that discussed? Like when you go to this conference, is there like a panel or whatever on building an eye? Is that a commonly discussed thing? I know there have been like a couple of efforts of making a retina or something like that.
Yeah, there are efforts in building components of the eye. Artificial cornea is probably at some point reachable. There are implants to replace the natural outflow tracts of the trabecular meshwork. That's somewhat working. And of course, intraocular lens is widely used, and that's been very successful. Building a retina is very difficult and fraught with risk. Optic nerve, I think almost impossible. Brain interface, maybe, actually somewhat more plausible, but also I think pretty far away in terms of really replacing the function of the natural eye. There are also people doing whole eye transplants, which also sounds pretty far-fetched. I don't predict that it will be successful in this 100 years because of the problem with nerve regeneration. You have to really solve that fundamental biological problem before you can tackle these specific applications.
You're saying that the problem is that the connection, the nerve connection between the eye and the brain doesn't basically regenerate.
Right. That's extremely difficult because it's not just the stimulating the nerve to grow, they have to form the proper connections. And that's a very special process that very difficult to recapitulate. I think replacing the eye with the transplant or implant is not something I'm working on now because I don't see it coming to fruition in the next few decades.
What's the limitation? Like if you have BCI type connection to something that's sensing photons, what's like the limitation? Is it the number of neurons that you're activating? Is it something else? What do you think is the fundamental limitation? If you can do Neuralink, why can't you do iLink? Is the number?
You mean like bypassing directly?
No, let's say you put into the eye a camera, and the camera has electrodes or something that connect to the neurons that send optical data into your brain. I'm just like, is there like a fundamental problem? For example, you need this many bits of data, the eye takes in this many bits, but like the Neuralink can do 1/100000th of that or whatever. Is it like a million neurons, but you can only connect to 10 or whatever? Is there some kind of like huge wall that has to be overcome?
That has been done. Subretinal and epiretinal implants have been developed and tried, and they do work to some extent. It gives you a low resolution, rudimentary type of vision that's not natural.
Like dark spots, light spots, that kind of thing.
Yeah. The electrodes are not dense enough, and we don't really know how to encode the signal so that the vision you get is natural. And company have been started and failed. I don't think it's something to be taken lightly because there are not many, but a sizable number of patients who had those implants that are no longer supported when the company fails. You're settled with a problem that cannot be really addressed effectively. Hopefully some deep pockets, maybe Neuralink can develop something that can be sustained. But even big companies abandon projects that are not really ready to make commercial profit.
There's a startup called Science, which is one of the founders of Neuralink started this company. But I think their approach, I don't understand how it applies to humans, but they do like an optical approach to stimulating the nerves. So there's a camera and then I don't know if they're still doing eyes. Maybe they've changed. But you have to genetically modify the neurons because to accept optical signals, they need to be genetically modified.
Yeah.
So I'm not sure how that works in humans. That's two things now together where you have to do gene therapy and then you have to do an implant. It's like the ultimate thing to get through the FDA. But that's one that I've heard of that looks pretty cool.
Optogenetics is interesting because even though, like you said, it requires two difficult technologies, it actually may be safer because you're not implanting a foreign body in the eye. Or gene therapy is foreign, but it's
not like a foreign.
It's not a hardware.
Yeah.
That can detach, can cause infection, and
But talking about hardware, you were also mentioning intraocular lenses, and these are typically nowadays static, like they have one or maybe two or three focal points. How likely do you think, or how easy, difficult is it to have adaptive implants, adaptive optics implants, because they will have to attach to the muscle that's already in your eye? Is that
Yeah,
even
yeah.
possible?
There are several groups working on that. Also, at about the same time that OCT was being developed, it's not quite ready yet. I think it's definitely possible. You just have to find something with the right compliance, the right connection to the muscles, and that's durable. The long-term biological reaction to it and neuroadaptation are probably somewhat difficult. I don't know. But it's not something easy because smart people have been working on it for decades. I see that that's something that it's plausible to have a breakthrough. But in terms of things that are hot besides direct connection to neurons is obviously artificial intelligence. And I think if you were wanting to make a clinical impact, that would be one area that has high likelihood of success. And certainly interpreting OCT or OCT angiography images and making diagnosis of not only eye diseases but systemic diseases is likely to succeed with artificial intelligence. And that's a big area of research that we're engaged in. And that's certainly a hot topic everywhere.
Are there any resources which you would recommend? Because for training AI tools, we need a lot of data, and I know, like in medical fields, this is like the main constraint, that it's hard to get enough data for training those models. If you can cover some of that part, what should the AI engineers do?
I think at this stage, there's a lot of work in building electronic health records, including advanced imaging like OCT, so that they are easily accessible and AI ready, either through centralized database or federated learning. You can access the images and have knowledge of their format in some standardized way, so you can use them to train neural networks. And that kind of infrastructure, foundational work is being done right now. Yeah, OCT is a little bit hard in that the images are not quite the same as photographs or video, ordinary images, so that it doesn't transfer as easily. But there are smart people working on that, and I don't think that it would be insurmountable. That's a relatively easy problem compared to regenerating the optic nerve, for example.
Have you in your lab perhaps already used this relatively new technology called a meta lens? There was a Nature Photonics paper on it where at the end of an OCT, normally it is a ball lens, which has spherical aberration. So now if you put a meta surface, you can quite easily correct those aberrations. Is this something that it does help with clarity of the image, but is it something that you see becoming a standard for OCT, or what is typically used instead in terms of optics to improve or suppress aberrations?
Yeah, I think that sounds like something that would be very useful for small probes, intravascular probe or endoscopic probes. Definitely think that that would be useful.
I feel like for also the one who involved with research and production of the meta surfaces, it sounds like OCT is one of the like perfect applications because of the bandwidth. It doesn't require like the full spectrum. So if it's within 50 nanometers bandwidth, that should be good enough, because usually that's the weak spot of the meta optics, that it's confined to narrow wavelength ranges.
I see.
But in this case, sounds like perfectly suits. But of course, there could be further nuances and further details to be considered.
And I don't know if that's useful for integrated optics. Is that another use? I'm asking you.
You can integrate it, but it is out of plane. So in integrated optics, like your interferometer would be in the chip plane. So these lenses, they would be out of plane either at the end of the chip. So assembling that would not be trivial. You could do that like out of the chip plane, but then it's more like a regular grating out coupler than a meta lens. It is possible, but it's more useful for when you have a sensor to have a meta surface on top of that to then project into the sensor. Yeah.
I think it's better to have two like separate modules. Let's say one which uses integrated photonics for like processing the signal, and then the optics, meta optics would use for collection.
Yeah, at the end of like the fiber probe.
Exactly. Okay, I think we're almost done. Any other questions, or do you have anything else to add to our today's conversation?
How often at your stage do you change your research projects? I want to ask you.
How often? Oh, it really depends. So I run a research group and it's in quantum gravitation. So the projects are very long. They're typically 5 to 10 years. But now, because we're doing more of these chip scale things, that's on a shorter scale. My rule is the moment we hit a deal breaker where fundamental physics prevents us from progressing further, we scrap everything, no matter how many $1 million we've spent on it. So this can happen early on, or this can happen late, but we keep pursuing, we stick with the projects as long as there's no physics telling us that we can't progress. And hopefully we've done our due diligence ahead of time that we don't run into these things, but you can't account for every little thing.
Yeah, for me, it's usually like I feel there's a law of about 5 years of spending, and it's interesting. Those cycles are quite related to funding and interest in general in the community. So, for example, I have done in the PhD, it's like a different type of work, which was very hot during 2010s, like from I did it like 2010 to 2011, 2017. Which is now probably no one would pay that much attention. So it seems like the fields are moving from like one area to another.
Yeah.
And for myself, I also feel like probably 5 years is a good time to invest fully. For me, it seems like 6, 7 years. So it's a little bit extended, but about the order of magnitude, let's say 5 years.
But earlier on, during my PhD, for instance, I was working in something called plasmonics, where you can kind of cycle the same methods very easily. So you can basically take a napkin, draw a new design based on some intuition you have, and then fabricating that and characterizing that. You can write a paper every month. So there I was changing projects a lot, but I was also finishing the projects because you could bring them to fruition very quickly, because at some point you had set up a production platform for going through the full process, where the only novelty would be inputting a design and then seeing if that does what you think it will do. But it's very much depends on the nature of the research subtopic. So there was very fast turnaround.
Wow, that sounds like so much fun. That's why I went into lasers and optics instead of tissue engineering, because you can try variations and assess results quickly. And
Yeah, you can have a lot of just ideas that are conceptual. So you spend most of your time on the concept, and then the whole process of building it and whatever's very standardized.
right, more fun conceptual work rather than the drudgery. But for me, I have a longer time horizon for changing research subjects, probably because it takes 5 years to develop the technology, then another 5 years or maybe even longer to find clinical applications and translate that and popularize it or commercialize it. So the whole pipeline is more than 10 years already. And I just gone through that with OCT and geography, where we started around 2011, starting that line of research, and commercialized was 2014. And CPT code was 2025. So there's like a 14-year. And I think gradually I would need to invent something new or go into a new line of research because that's getting too mature. So that's 14 years. And it's nice to have a long career to be able to change direction a few times.
Could you share how do you decide what is the project you would like to embark on, or if it's a good idea to do this research or that? What was your kind of strategy? Or...
I think I try to pick research areas where there's no technology that's being used clinically yet, but it's possible, it's plausible, and the technology is matured to a stage where that's possible. And for OCT, that's often dictated by how fast the image acquisition speed is. And then finding a new concept that is unique, that solves the bottleneck, the last mile to actual clinical translation. For OCT angiography, for example, is coming up with the efficient algorithm that improves the quality of the flow signal.
I feel like in AI, you don't have to scan like the whole thing. You can skip some of the parts so it can, fill up the rest. So that could be just an idea how to improve the speed. It's like
yeah. People do that already. I'm a little dubious of that because sometimes it works, sometimes you manufacture whatever you synthesize to fill in the blanks turn out to produce false negative or false positive diagnosis. So I don't like that much. But what was I saying? Oh, and of course, finding an area that's going to make clinical impact for OCT angiography. A lot of blinding diseases are vascular or have a vascular component. And so I knew that it would be really useful. And it's tough to find something like that. You have to go through a lot of ideas to find one that's going to have long legs in terms of both technological feasibility and big clinical translation.
Also interesting about like the eye diseases, what's like the origin of them? Most of them, like AMD, glaucoma, is this just genetics or there is some other things which contribute to those diseases?
The major blinding diseases are all age-related, and they have a genetic component in that genetics affect susceptibility. But I suspect if we live long enough, we will all develop these type of degenerations in the macula or in the optic nerve, age-related macular degeneration or glaucoma. And then diabetes is, of course, also age-related.
Is there anything to reverse? Like as I have heard, glaucoma is not reversible, right? It's more how to delay.
Right, to delay the progression.
But is there a way to treat fully those diseases, like reverse in a certain way? Or...
Not yet. Although I think some damage to the retinal ganglion cells in glaucoma may be irreversible because the ganglion cells have died and gone away. But some of the visual field defects in glaucoma are probably due to ganglion cells being dysfunctional, because we do see recovery in terms of at least perfusion when we effectively lower eye pressure. So you can probably see partial reversibility. But yeah, a lot of that damage is irreversible. And even normal eyes, when we age, we lose retinal ganglion cells. It's probably something like 0.2% a year. But if we live long enough, that will become significant. But we don't live long enough, so don't worry yet.
We are wrapping up our podcast episode, and it was really interesting and insightful conversation with you about your story, about the invention of the optical coherence tomography, both like research, engineering, as well as the clinical studies you're involved in, to see like the past, what happened, and where is it heading in the future.
Well, thank you. It was really fun to talk to you, where I don't have to avoid using big words like interferometer. That was nice.